Good morning, everybody. And at the outset, I am highly grateful to ISOT Scientific Committee 25, who has given me the opportunity to speak about recurrence of membranous nephropathy post-transplant. So now from mesangium to membrane, let us move from our last speaker. I'll be starting my presentation with two case scenarios. She is a 52-year-old female, had nephrotic syndrome 18 months after a live-related donor kidney transplant. Biopsy showed a membranous pattern, and immunofluorescence reveals IgG1 and G3 dominance, not IgG4. PLAR was negative. So what can be the most likely explanation for this finding? It can be a recurrent primary membranous, it can be a de novo membranous, CNI toxicity, or FSGS recurrence. Just keep the answer in your mind. The second case scenario is a 47-year-old male who had a recurrent membranous nephropathy post-transplant, and he comes to the nephrologist and asks about his prognosis. His biopsy confirmed a recurrent membranous with IgG4 and PLAR2 positive, and he was started on rituximab. So what can be a correct prognostic statement? The graft survival is similar to a non-recurrent patient. Untreated recurrence often leads to progressive graft dysfunction, but rituximab can stabilize the disease. All patients with recurrence loses graft within 3 years, or de novo has a better prognosis than recurrent membranous. So let us see what the answers comes in my presentation. Post-transplant membranous nephropathy presents in 4 scenarios. It can be a recurrence of primary nephropathy, which is autoimmune, de novo, which can be an alloimmune, recurrence of secondary membranous post-lupus, and then a membranous associated with chronic graft versus host disease after allogenic stem cell transplant. My talk will be surrounding recurrence and de novo. So coming on to recurrence first, which occurs in 10 to 45% of the patient post-transplant, and those centers which perform kidney biopsy, protocol biopsy, reports higher incidence and earlier recurrence. The recurrence is usually linked to the same antibody which is there in the native membranous, that is either PLAR or THSD7A, and if it is present, then graft loss is up to 70%, 50%. What are the risk factors? High level of proteinuria pre-transplant is one of the most common risk factors for development of recurrent membranous nephropathy, faster progression to end-stage kidney disease. If there is a low albumin pre-transplant, duration of dialysis, if it is shorter pre-transplant, can again lead to recurrence. And the most common again is anti-PLAR titer. This is a study published in Transplantation 2015, where what they found was that those patients who had recurrence, more than 90% of these patients had anti-PLAR antibody present pre-transplant, whereas those patients who does not have recurrence, the anti-PLAR antibody was absent pre-transplant. Again, one study from American Journal of Transplant 24, where recurrence rate was around 31%, and if there is a presence of pre-transplant antibody, then there is high chances of development of membranous, with a sensitivity of 85% and specificity of 91% respectively for predicting the membranous nephropathy recurrence. What is most important to see in this paper was the median time to recurrence. If the anti-PLAR titer pre-transplant was higher, that is 150 relative units per ml, then the recurrence time was only 0.57 years, whereas if it is less than 150 units per ml, then the recurrence time was 1.78 years. Again, going to risk factors, genetic polymorphism also plays a role, and those patients who has HLA-A3 antigen, recipients have HLA-A3 antigen, will have 2.5-fold increased risk of recurrence, and same polymorphism has been described in donor PLA2R1 and HLA-D antigen. So whenever a patient comes to us, he comes with a diagnosis of membranous nephropathy going to ESRD. But we all know that from last 7-8 years, we are able to stain the biopsy with PLA2R antigen. So if the patient is prior to that, what can we do? If we have a block, then we can immune stain for C2C, whether the patient is having a PLAR2 within the immune deposit or not. And at the time he comes to us, we can also measure anti-PLAR antibodies in the patient's serum. Now, what is the benefit of measuring that antibody? If serum antibodies are undetectable, then no further testing is required. But if serum anti-PLAR antibodies are detected, then we should measure them annually till the time of transplant, because then there is a high risk of recurrence of membranous nephropathy. One important thing to note, that if the patient is having anti-PLAR antibody more than 150 units at the time of detection, then the rate of recurrence is very high, and at that time prior to transplant, we have to go for a preemptive treatment, and that treatment is in form of rituximab with or without plasmapheresis. Now, how does these recurrence of membranous nephropathy patient present post-transplant? They occur usually between 13 to 15 months after transplant, but may occur early or even late in years. The presentation is either subnephrotic or nephrotic range proteinuria, but the graft function is preserved initially. In one study which is published in CJAS in 2010, 80% of the patient had a protein excretion of 150 milligram per 24 hours, and out of these 80% patient, more than 90% patient had proteinuria in the nephrotic range. The course can be indolent, but may lead to progressive graft dysfunction over time. Graft risk loss was increased as compared to non-recurrent case, but if it is properly managed, then it is not inevitable. Once we do a transplant in a patient who has membranous nephropathy, what is the thing we should do for surveillance? We should measure creatinine and urine UPCR monthly for at least 6 to 12 months after transplant and every 3 to 6 months thereafter. If the patient had a serum antiplatelet antibody level positive or negative, we should measure the levels 1 to 3 months for the first 6 to 12 months after transplant, depending on the status. And if the patient is having a very high antiplatelet antibody level, then we should measure it every monthly till first year of his post-transplant life. The diagnosis again is with kidney allograft biopsy, and a study published in American Journal of Transplant 2011, 50% of the patients who had recurrent membranous nephropathy were seropositive for antiplatelet, and they also had antiplatelet antigen positive in the immune deposit on the biopsy of the allograft. One study in 2013 published in Transplantation, platelet staining within deposit had a sensitivity of 83% and specificity of 92% in those patients who had recurrence of membranous nephropathy. So when we come to this slide, which is the left half of this picture, there is an environmental trigger or there is a genetic susceptibility which leads to development of subepithelial immune complexes which are deposited in the subepithelial region. The A shows us the IgG4, which is there in and which is the formation of the antiplatelet antibody, and B shows the deposition of antigen. So whenever you have an IgG4 and antiplatelet antigen being deposited, we label this patient as a recurrent membranous nephropathy. Coming on to de novo membranous nephropathy, the incidence is 1.5 to 2%. Onset is between 4 to 9 years post-transplant. It is more common in pediatric population. And one study published in 1994 in Clinical Nephrology, 9% of the patient developed recurrent de novo membranous nephropathy in the 530 allograft biopsy done at that time. And if the patient had de novo membranous, the graft loss is around 50%. Most common cause associated with de novo is association of chronic antibody-mediated rejection. This is present in around 80% of the cases. 20% of these patients present in de novo are associated with infection, malignancy, renal infarction, ureteral obstruction, or having therapy of antivascular endothelial growth factor therapy, commonly in graft versus host disease. Now, what is the pathogenesis? Patient had a rejection. So now once the rejection is there, there is exposure of previously undetected glomerular antigen, which leads to a humoral response. Now this humoral response alters the glomerular basement membrane and facilitates the formation of subepithelial immune deposit. And this immune deposit is IgG1, which is predominating in the de novo membranous. So a kidney biopsy of a patient who had de novo membranous often shows findings of both membranous as well as of antibody-mediated rejection along with presence of DSA. And these patients are PLAR negative. So, do we have any antigen for de novo? This was a study published in Kidney International 2024 by Sethi et al. They had 18 cases of de novo membranous, out of which 7 were associated with ABMR. They did a mass spectrometry of these patients, and immunohistochemistry confirmed that there was a glomerular staining of FAT1 in the mesangium and along the glomerular basement membrane. So they concluded that there is a target antigen protoadherin FAT in the subset, that is around 50%, 7% of the patient who had de novo membranous nephropathy with concurrent antibody-mediated rejection. Now the other half of that slide, de novo membranous nephropathy, we have virus, neoplasia, ureteral obstruction or rejection, all lead to a formation of a immune complex which is IgG1 now. This is IgG4, this is IgG1 in de novo, and these deposits are, these immune complex are deposited again at the subepithelial space, which you can see in C. And in E, what you see is the staining of IgG1 immune complex, which is corroborating with de novo membranous nephropathy. How does these patients present? Usually they present between 63 to 102 months, usually are asymptomatic, but in 33% of the cases, they have subnephrotic range proteinuria. Diagnosis of de novo is not typically associated with anti-PLAR, as I previously told. Neither there is a positive tissue staining of the PLAR antigen with the immune deposit. IgG1 is the predominant immunoglobulin which is present in de novo membranous nephropathy. So kidney biopsy shows de novo membranous, kidney biopsy shows findings of both membranous nephropathy and rejection in patient who presents with de novo membranous. Along with that, you will have presence of DSA, which again are characteristic of antibody-mediated rejection. So to summarize, how to differentiate between a recurrent membranous and a de novo. Earlier appearance of membranous nephropathy in biopsy is suggestive of recurrent membranous nephropathy because the recurrence rate is 45% and it appears early, whereas de novo appears late and it is more common in pediatric population. The pathogenesis of recurrent is anti-PLAR antigen, which is again at the time of transplant if present is a major risk factor. Whereas in de novo, it is not fully known, but if it is associated with antibody-mediated rejection. Patient of recurrent presents with lower amount of proteinuria, subnephrotic to nephrotic range, whereas de novo are asymptomatic and only 33% had subnephrotic proteinuria. On diagnosis, there is positive antigen staining of PLAR in recurrent with IgG4 as a dominant subclass. In de novo, it is not associated with PLAR, and there are evidence of chronic antibody-mediated rejection with IgG1 as a predominant IgG subclass. And you may find IgG3 also. On electron microscopy, recurrent presents with classical subepithelial deposits like spikes, and de novo presents with subepithelial deposit along with additional endothelial injury. So what is the treatment? I'll be dividing the treatment into recurrent and de novo. So the standard dose of triple immunosuppression which we give post-transplant does not seem to protect against or change the course of disease. And recurrent treatment is divided into two subtypes as per severity, whether it is mild or moderate to severe disease. So what is mild disease? When the proteinuria is less than 1 gram, stable kidney function, and only histological evidence of recurrence as detected by protocol biopsy. Here you don't require any immunosuppressive therapy, only supportive measure in form of RAS inhibitors, rigorous blood pressure control, treatment of lipids, diuretic or edema management, and anticoagulation. Monitor UPCR and creatinine every 3 months in spite of that the patient is having a mild disease. If PLAR-associated membranous is there, then you should also measure PLAR antibody level every 3 months. Treatment of moderate to severe disease, which is characterized by more than 1 gram of proteinuria. The drug of choice is rituximab with supportive measures. The recommended dose is 1 gram on day 0 and day 14. Monitor both UPCR and every 2 to 3 months as well as antibody level. If the antibody levels are undetectable, we say that the patient had improvement, or if there is a decreased proteinuria, we say that he is having a positive response. But if the patient does not have a decrease in protein excretion or in the levels of anti-PLAR antibody level after 4 to 6 months of rituximab therapy, then rituximab therapy can be given second time. And only thing to remember is that at that time CD19 plus B cell count should increase to greater than 1% and proteinuria should be increased by more than 1 gram per day. Only then we should be giving rituximab in these patients. If the patient does not have any decline in protein excretion or in the levels of antibody, despite 2 courses of rituximab given 4 to 6 months apart, we label these patients as resistant disease. Now, what is the treatment of resistant disease? The drug of choice again is cyclophosphamide, which is to be given orally in a dose of 2 milligram per kilogram per day for 8 to 12 weeks. At that time, when you start cyclophosphamide, discontinue any antimetabolite, whether it is azathioprine or mycophenolate, because of more chances of bone marrow suppression. Other anti-rejection medicine like CNA and glucocorticoid should be continued. This is a study published in Transplantation 2016, where a retrospective analysis of 63 allograft patients with primary membranous nephropathy was done, out of which 61% patient had PLAR positive. 30 patients out of these 63 patients developed a recurrence, and 53% were diagnosed by a protocol biopsy. What is important to see is that 17 patients had a clinical progression and they were treated with rituximab. Complete remission was there in 9, partial remission was there in 5. So overall response rate was 82%. 5 patients out of 11 had a graft loss due to recurrence, but there in the cohort there was no overall impact of recurrence in the graft survival when this study was published. One more study published in AGT 2024, there 31% patient developed recurrent membranous over 10 years, and those patients who had rituximab along with supportive measures had a higher rate of partial or complete remission, that was 68% as compared to supportive therapy, which was only 33%. Now, is there anything beyond rituximab? Because many times we see rituximab antibodies, we see the patient is not responding to even rituximab and cyclophosphamide. So newer drugs have been tried, anti-CD20 monoclonal antibody with double filtration plaques with MMF or cyclophosphamide, then proteasome inhibitors or anti-CD38 monoclonal antibody. Trials were there, but conclusive evidence are still awaited. Prognosis, again a study published in 2024, 10-year graft survival was similar in both patients who had recurrent or does not have a recurrence of membranous, 87% and 90% respectively. As far as treatment of de novo is concerned, optimal treatment of de novo membranous is not known. Due to strong association of de novo with antibody-mediated rejection, the treatment of rejection is paramount. But there are some protocols being described. If the patient has a less than 4 gram of protein excretion with stable kidney function, you only augment the immunosuppression, though there is no good data that supports this approach. But if the patient has protein excretion of more than 4 gram or have a deteriorating kidney function, rituximab can be given in a dose of 1 gram at day 0 and day 14. If again there is no response, cyclophosphamide or high-dose alternate day steroids can be given for 8 to 12 weeks. And if patient had chronic rejection, along with de novo membranous, plasmapheresis may be considered but has a dubious role. What are the pitfalls we should remember whenever a patient of recurrent membranous nephropathy comes to us? That many times you can have presence of PLAR antibody after transplant, but there is no proteinuria. So you do not say that the patient is having a relapse. Second, many times patient can develop membranous nephropathy, but PLAR antibodies have disappeared. And this occurs in around 20% of the patient. And this is known as sink mechanism, where you have evidence of membranous nephropathy on the biopsy, but PLAR antibodies are absent. Third condition where PLAR antibodies can be present many years after kidney transplant and can herald a late onset of occurrence. Important pitfall to remember is that rituximab treatment is guided only by proteinuria, not by the antibody level. And if proteinuria is more than 1 gram per day, then you treat the patient. And there is no supportive evidence where if a patient had a recurrence of histological recurrence of membranous, but proteinuria, if it is less than 1 gram, that rituximab is helpful. So coming on to the case scenario back, again we have IgG1 and IgG3. So here the answer is de novo membranous because the patient is having PLAR stain negative and no IgG4. And just 2 more. And the second case about the prognosis, untreated recurrence often lead to progressive graft function, but rituximab can stabilize the disease. So to summarize, recurrence of primary membranous is early as compared to de novo. Higher recurrence rate if the higher prior antibody at the time of transplantation. De novo membranous is typically an autoimmune disease linked to chronic antibody-mediated rejection characterized by IgG1, G3, PLAR negativity, and often C4d positivity. Detection of PLAR antigen can clearly differentiate between recurrence and de novo membranous. Rituximab is currently the first-line therapy. Prognosis depends on prompt diagnosis, serological monitoring, and target immunosuppression. And second-line therapy is cyclophosphamide, which require anti-metabolite discontinuation. Thank you.